Good evening, everyone. Today we are having the second session of OSCE. Basically, as I told you in the previous session also, it is to concentrate on the exam going IDCCM as well as the EDIC Part 2 candidates. If we have any doubts in between the session also, you can stop and ask some questions. Okay, I'll also try to different scenario you might get whenever you're doing the OSCE sessions. Okay. Today it's basically cardiac one. Trainee will be Dr. Sanjana. Shall we start, Dr. Sanjana?
Yes, sir.
Can you be slightly loud, Sanjana? Your voice is
Sure, sir. Am I audible now?
you are audible, but if you are loud, it will be easy.
Okay, yeah.
A 60-year-old known diabetes patient was found unresponsive in a lake at sub-zero temperature. On examination, he found that there is no pulse. Okay, what are your differentials for these patients, Sanjana, and how will you approach?
This patient is a 60-year-old and was found unresponsive in a lake. So first would be a cardiac arrest,
Yes,
and next would be hypothermia because of sub-zero temperature.
yes, very good.
And known diabetic, so I would like to think of hypoglycemia as well in this patient.
Yes, very well. Then any other differential you
And
have?
other differentials would be again any cardiac event like an acute coronary syndrome,
Hmm.
which would have led to the cardiac arrest.
Yes, very good. If others are interested, they can put in the chat box. We'll see about it. Okay. You have any more differentials? So that's it. This is a real scenario which has come in the EDIC exam also.
Okay.
Okay. So it basically patient is having a cardiac arrest. It doesn't have any pulse. Okay. So in specifically in this context, our primary diagnosis might be hypothermia per se, gradually worsen, might have led to this. Other positive should always consider is trauma. Okay, might be swimming, you might have had a shallow water, you might have had a spinal cord injury or head injury. Other causes are toxicological causes. Example, alcohol or drug overdose you should suspect in these kind of patients. Medical conditions, myocardial infarction, stroke, seizures, metabolic disorders like hypoglycemia and hypothyroidism, you should always suspect in these kind of cases. Clear, Dr. Sanjana?
Yes, sir.
Yes, very good. If you don't remember also, always stick to your 5H and 5Ts. It will give most
Okay.
of the answers. So even if you don't know, you don't have to worry in that case. You might get most of the calls here. You might miss certain calls, especially in this context, in this case. But always remember that in case of hypothermia with cardiac arrest, you have to rule out these causes. Okay?
Yes, sir.
Okay, that's good. Okay, how will you manage this patient?
So this patient has been found unresponsive and there is no pulse. So I would like to call for help, and according to the BLS and ACLS protocol, I would start CPR.
Yes.
And so CPR again, 30 is to 2 rescue breaths also has to be given. Um,
Okay.
and yeah, that will be at the scene. And once help arrives, if there is an AED, we can connect the AED. And also we'll have to look at the temperature of the patient, because this patient has been at sub-zero temperatures. So defibrillation might be a little difficult in this patient. So we'll continue with the CPR, and once help arrives, we have to resuscitate according to the ACLS protocol after looking at the rhythm. If
How long you might resuscitate?
uh, so till there is no particular duration, but since this patient is hypothermic, the duration might be a little prolonged compared to the other patients.
Okay. Any specific this thing goal we would like to have when we are doing a CPR for an hypothermic patient?
Specific goal in case of rewarming, sir?
Yes, very good. Go ahead.
Yeah. So rewarming has to be depends on the patient's initial temperature. We'll
Hmm.
have to check the temperature. And if it is less than 28 degrees Celsius, the rewarming rate will be at 1 degree Celsius per hour. And the process should be done over at least a period of 24 hours.
Hmm.
And so initially at the scene, what can be done is removing of the wet clothes and then rewarming with the help of a blanket or
Hmm.
and any other thing that can help to retain the warmth that is available in the surroundings. And later, once help arrives, we can start with warm IV fluids and
Okay.
yeah, other forms of active rewarming like
Okay.
rice tube and feeding, bladder irrigation.
Okay, that's great. Is there any specific things regarding to the giving adrenaline or giving any medicines related to the resuscitation per se and giving defibrillation? Any specific consideration we have to do?
Yes, sir. And since this patient is hypothermic, so we will have to give at least thrice according to
Yes.
the latest ACLS guidelines.
Right. So you said most of things correct. You have to follow ACLS algorithm, whatever the condition is there. Less than 30-degree defibrillation effect may or may not be that effective. Okay. More than 30 degrees, it will be better tolerated compared to less than 30 degree. If it's mild hypothermia, you can use passive external warming. If it is severe hypothermia, you can use a lot of different techniques. And adrenaline dose, if it is below 30, it is of no use. You can give adrenaline if it is more than 30 degree, and the duration should be doubled compared to whatever is the normal duration till it reaches 35 degree. We can consider even advanced rewarming methods as ECMO also. In recent this thing, it has come up. We can add ECMO also into that. Okay,
Yes, sir.
you got it?
Yes, sir.
Very good. Okay. Okay. RIC was achieved for this patient after 30 minutes of CPR. Patient was intubated and ventilated. You noted the vitals. Vitals is heart rate of 30, BP of 90/60, saturation of 96 and a pivot of 50%. Respiratory rate you kept on the ventilator of 24. GCS is even VT M1, pupils bilateral equally and reacting to light. Air entry is equal. GRBC is 180. You have done a pH. pH shows ABG shows a pH of 7.2, PO2 of 96, PCO2 of 42, bicarb of 16, and lactate of 4.2. Can you tell me what are the abnormalities are there in this?
Yes, sir. So, this patient, there is bradycardia and hypotension, and and the patient's sensorium is on the lower side, and the patient is on ventilatory support. And ABG is showing metabolic acidosis with hyperlactatemia.
ABG only metabolic acidosis?
Lactic acidosis is also there, and we'll have to check for the
Okay.
compensation.
Did you mention about the heart rate?
Yes, sir, bradycardia and hypotension.
Okay, fine. So findings in this patient is symptomatic bradycardia with hypertension is there. There is both respiratory and metabolic acidosis is there with raised lactate.
Okay.
Okay, and low GCS. See, in this, in EDIC and all, you don't have to be accurate with compensation and all, but
Okay.
you should know what exactly is there. Okay, because example, a question like this a symptomatic bradycardia and hypertension might carry 5 marks for you, whereas metabolic and respiratory cirrhosis, if you tell both, you might get 3 marks. Otherwise, you might not get that 3 marks. Okay,
Okay, sir.
okay. How will you approach this patient?
Approach will be according to the ABCD protocol. So airway has been secured in this patient, and the patient has been intubated,
Hmm.
is on ventilatory support. Next, I would like to go with the breathing. I would like to auscultate. I would like to look for the chest movement. Um, and yeah, also look at the thorax if there is any injury, since the patient has drowned, any other injuries that is possible. I would like to auscultate and look for crepitations or any, also percussion to look for any pneumothorax. Then I would like to go to the circulations. This patient is having bradycardia and hypotension. I would like to secure wide bore cannulas and start with fluid resuscitation initially. And also, since this is a symptomatic bradycardia, I would like to go ahead with atropine and also do an ECG and look at the rhythm and see if the patient is having any heart block. And if the patient's blood pressure is not improving despite fluid resuscitation, I would like to start with vasopressor support.
Okay.
Yeah, and
That's good. Okay.
yeah.
And investigations, what all investigations you'd like to do?
Investigations, I would like to do the basic investigations first. ABG has already been done. I would like to, since this patient has come with bradycardia, hypotension, and unresponsiveness post cardiac arrest, I would like to do an ECG, echocardiogram. I would like to look at, since the patient has been diabetic, I would like to check the blood sugar levels, and also look for ketone bodies if the patient has had to suspect any decay, and also other investigations like echo. I think I mentioned also cardiac enzymes. I would like to do this patient.
Okay.
And other basic investigations like complete blood count, serum electrolytes, including calcium, magnesium, and phosphorus, renal and renal function test.
Yes, very good. So you covered most of the things. Only DCJ, drop ICBC, renal panel, maybe LFT may or may not. That's okay. Okay. This is the ECG of the patient. You have done a early ECG. Can you interpret this?
Yes, sir. So this is the patient is having a bradycardia here and prolongation of PR interval, and also there is widespread ST elevations in 2, 3 AVF, 2, 3 and AVF, and also so there is bradycardia with features of heart block and inferior wall MI. So I would like to think of a right coronary artery involvement in this patient.
Okay. Okay. This patient, what about heart block? What degree heart block you said?
So this looks like a complete heart block.
Yes, very good. It looks like complete heart block only. So, this patient was diagnosed with inferior ST elevation MI with third degree heart block and slow junctional escape rhythm. Okay. So how will you manage this patient now?
First I would so this patient is having a complete heart block with inferior wall MI. I would like to think of right RCA involvement, and initially, since this is symptomatic bradycardia, I would like to give atropine up to 3 milligrams. And if the patient is still symptomatic, I would like to start the patient on adrenaline infusion. I would like to involve the cardiology team as well, and the patient might require pacing and also percutaneous coronary intervention might be required as early as possible.
So do you think which one takes precedence? Temporary pacemaker insertion or reperfusion, coronary reperfusion?
So here, pacemaker.
Always it is said that you should always try for reperfusion
Okay.
because once you achieve reperfusion, your bradycardia will get
Bradycardia will
resolved.
settle. Okay.
Okay. So always try for reperfusion. Very good. So bradycardia management as I told already. So always you should also mention that you should give loading dose of
Loading
antiplatelet.
doses of antiplatelet. Yeah.
Okay. What will you give with your practice?
So aspirin 325,
Mm.
and clopidogrel or ticagrelor, either of
Okay.
it.
Which one do
180
you use?
ticagrelor is preferred, 180 mg loading dose. And also we can load the patient with heparin.
Yes. Okay. In this patient, we can consider targeted temperature management also.
Yeah.
Okay. One important thing you should mention is to avoid NTG in these patients.
Okay, sir.
Okay. Okay, if CAG was done, patient underwent CAG, showed double vessel disease affecting RCA 90% block and LCX 70% block. Okay, significant stenosis, both arteries are there. But cardiologist feels that RCA is the primary lesion.
Hmm.
Okay.
Okay.
Plan of action now.
Since RCA is the culprit vessel, reperfusion has to be achieved, and probably a PCI to RCA is preferred than both vessels that are involved. And post that, again, the patient has to be monitored, hemodynamic monitoring, containing antiplatelets, and depending on the thrombus load, the patient might even be started on a tirofiban infusion. And along with antiplatelets, anticoagulation can also be started. And yeah.
You will whether it, sorry, I missed you. Whether you are going to treat both the lesions or not.
No, only the culprit vessel has to be addressed.
Okay, that's very important. No need to treat all the lesions. The culprit lesion only should be reperfused in case of STEMI in acute scenarios. They found that there was a
Yes.
mortality benefit. If you try to do both the things, there was a high mortality. Maybe mainly because they might be spending more time in the cath lab instead of stabilization of the patient. Okay. So in
Yes.
this MDT team was done a intervention cardiologist and cardiac surgeon to decide what intervention we have to do, whether CABG is feasible or a angioplasty. They decide that will they treat only culprit lesion. Patient underwent angioplasty with drug-eluting stent to RCA, continued on DAPT. Post angioplasty is ST changes resolved along with the resolution of bradycardia. Post procedure day 1, you noted that patient is having AK, creatinine of 1.7, burn of 25. Total count you noted that it's around 25,000. Platelet is 2 lakh. Neutrophil 75%, lymphocyte 10, eosinophil 10%, and monocyte of 4%. Lactates of 2.
Okay.
What's your differential? This is the patient foot. Okay. What are your differentials?
So here the patient has developed acute kidney injury. One could be because of the patient's underlying cardiac condition. The patient had hypotension and bradycardia, so that could have resulted in renal injury because of hypoperfusion. So I would like to think of a pre-renal acute kidney injury. And also considering the patient's foot, I would like to
It's okay, try. Don't worry.
the pedicle. So can I look at the image again? Okay. So here lactate is not that elevated. It is only few pedicle lesions. So it could be if the patient if the patient is in shock, we can think of seps.
Patient is
Sorry,
not in shock. Actually, I achieved a resolution
okay,
of shock when
okay,
bradycardia is accepted now.
okay. It could be because of the acute kidney injury or the contrast that was given
Okay.
during angiogram.
Yeah, that's very good differentials. But in this patient, anybody else can if you know, you can tell me. I know that a lot of people are putting the chat box. Any other answers? It is cholesterol emboli syndrome.
Cholesterol embolism, yeah.
You have seen it, but Sanjana,
So,
you have seen it.
yes, sir.
Yeah. So it is cholesterol embolism syndrome. It can be multiple differentials will be there. As you said, it can give an AK. It can be due to AK related to the shock per se, or it can be contrast induced AK. But day one and post procedure day one is unlikely. Other differentials will be vasculitis or peripheral illness, or it can be thromboembolism. It can give any differentials at the but the diagnosis in
Cholesterol
this patient
embolism.
was cholesterol embolism syndrome. And if you look at the total counts carefully, there was a eosinophilia also in that.
Yeah.
Okay.
Okay.
Post procedure day 3. Patient developed hypoxemia with hypotension. A patient is on ventilator, PRVC mode. Saturation is 88% with FiO2 of 70. Heart rate of 135 beats per minute. BP of 80 by 50. And systemic examination, patient noted to have bibasic reps with elevated JVP. What are your differentials?
This patient is on ventilator with a high FiO2 requirement, and even on 70% of FiO2, the saturation is only 88. The patient is also having hypotension, and there is bilateral bibasal crepitations with raised JVP. And it was an RCA involvement. I would like to think of right heart failure,
Hmm.
cardiogenic pulmonary edema, ARDS. I would also like to think of any pneumonia or any aspiration pneumonitis, since the patient had drowned, later was on ventilatory support, any ventilator associated pneumonia and sepsis.
Okay. Can you list the complications related to the ACS? Sangana?
Yeah, complications of ACS will be cardiogenic shock, uh,
Yes.
uh, papillary muscle rupture, ventricular septal
Papillary muscle rupture will lead to what?
regurgitation, mitral
Yes.
regurgitation.
Yes. Then.
There can be ventricular septal rupture as well.
Hmm.
Arrhythmias.
Hmm. Yes. See, in the context of ACS, no, especially day three, you should still think that there might be ACS related
Okay, okay,
complications,
okay.
right?
Yes, sir.
So it can be, as you told, it can be ventricular septal rupture. It can be free wall rupture with cardiac tamponade. It can be acute mitral regurgitation. It can be stent thrombosis, pulmonary edema due to LV dysfunction per se, right ventricular failure, and arrhythmia, as you rightly told.
Okay.
Okay. So, what all investigations we would like to do in these patients?
In this patient, again, I would like to go ahead and do an ECG echocardiogram to look at the heart function, a chest X-ray, if there, and also a complete blood count to look at the if there is any inflammatory infective picture. Uh, Also, I would like to do an anti-bro BNP and repeat a troponin to look at the trend if there is elevation or if it is trending downwards. Um, yeah.
Just a query in this. Hello.
So yes, sir.
In case of repeat myocardial infarction, what enzyme marker might be better?
In repeat myoglobin or CKMB.
No, CKMB. Yes, very good. Okay. Then, so you'd like in this patient, echo was done, TTE or TEB, any one of them. ECG was repeated, ABG was done, repeat CKMB was done, chest X-ray along with bedside ultrasound. It was also decided to put advanced cardiac output monitoring in this patient. Which are the advanced cardiac output monitoring generally we refer to?
So PICO, pulmonary artery
Yes.
catheter,
Pico and
LIDCO.
no, something which is more common than LEDCO.
Mm, Pulmonary artery catheter.
Yes,
Uh,
pulmonary artery catheter. Okay.
mm,
In echo showed EF of 30% in this with severe mitral regurgitation with posterior hypokinesia. Patient continued to have hypertension even on noradrenaline of 3 mg per kg per minute. Pulmonary catheter was inserted in this patient, which showed cardiac index of 2, pulmonary systolic pressure of 50, JVP of 14, CKMB was elevated. What is your next approach?
so here the patient is in shock, but the cardiac index is 2. We consider cardiogenic shock if it is less than 2. And there is also severe mitral regurgitation with posterior wall hypokinesia. And
Hmm.
CKMB is elevated, so it could be another acute coronary event.
Hmm.
So I would like to again uh, involve the cardiologist, and the patient might like need a relook angio.
Okay, what are the vessels which are involved in double vessel disease?
Right coronary artery
And
and left LAD, left anterior.
LCX also involved.
And
Okay, what do you think this might be?
uh, this might be since posterior wall hypokinesia is there in mitral regurgitation, it could be a rethrombosis.
No, this is a different territory, no, Sanjana. It might be LCX
That
involvement.
that
It can be RC
It
also,
was a
but most
new
like
that
uh,
initial was RCA involvement.
yes, initial RC involvement. It
Okay.
can be that one other vessel also might have been blocked.
Oh, oh yeah, but that was not stented.
Yes, it
And
was not
here
stented.
it will be it could be because of the other vessel.
Yes. Okay.
Yeah.
So you should mention all these things in this. Okay.
Okay.
Here because it is a there's a new RWMA which was not there before. Again, we should have a multidisciplinary team meeting, including cardiologist and a cardiothoracic surgeon. We'll add diuretics. In this patient, especially, we'll consider rhinodilator, right?
Yes, sir.
We have maxed out on the dose of already noradrenaline. Rhinodilator is better. Especially in this context, either dopamine or milrinone will be considered. And also IABP was inserted in this patient. Okay. It was decided to take up for surgery and do surgical repair of the mitral valve repair along with CABG for that vessel. Intra-op was uneventful. Patient was shifted to the ICU. Over next to 3 days, patient condition improved and patient was gradually weaned off vasoactive drugs. Post-op day 4, mitral valve repair and CABG. Patient was noted to have hydrogen output which was more than 1 liter per day. Okay, what are your differentials?
So high drain output could be because any bleeding from the operative site. We need to see if it is hemorrhagic bleeding or just serosanguinous drain. Also look at if there was any drop in hemoglobin, look at do a check echo to see if there is any collection, and also do an ABG to look at the lactate levels.
Okay. Any other conditions it might cause hydrogen output? Just guess. Any guesses? Can it be infective?
Yeah, can be
It can be infective.
infection. Yeah.
Okay. So in this patient, our differential way, it can be pleural effusion per se. It can be due to volume overload. Sometimes the drain output will continue to be high because of effusion per se. It can be bleeding. It can be infection. It can be due to chylothorax. Very rarely this condition is seen. Okay.
Okay.
Further
Yes,
top
sir.
of the drain showed high triglyceride indicating chylothorax.
Chylothorax.
Okay. How will you manage?
For this patient, since the patient is having a chylothorax and the drain is already in situ, we need to keep monitoring the drain output. And also, we'll have to see if there is any injury to the duct and involving the CTVS team again. And for the drainage or the ligation of the thoracic duct.
Okay. Good.
And maybe embolization or any interventional radiology approach can also be considered.
Very good.
Mm.
Anything simple? What is the content of the file?
Low fat diet.
Yes, very good. Okay. Any medical line you are aware of?
Uh, Medical line of management for statins and fibrates.
No. Okay. Octreotide. Okay. Octreotide is supposed
Octreotide.
to decrease
Yeah.
the drain
Yeah.
output. Okay.
Okay, sir.
Okay. You will continue the chest drain. Initiate a low fat diet with medium chain triglyceride. Medical therapies, you can give octreotide or somatostatin analog, any other, which will decrease the chyle flow. Surgical intervention, as I correctly told, it can be a surgeon or it can be interventional radius. It involves embolization or duct ligation. Okay. In
Okay.
this, especially in the condition of chylothorax, it can consider placing a pleuroperitoneal stent.
Yes,
Okay.
sir.
Okay. Patient continue to have low GCS. Okay. Sorry. What are your differentials?
So low sensorium. Post this procedure, I would like to think of any infection and septic encephalopathy, electrolyte abnormalities. Since the patient I would like to also rule out any intracranial causes like a bleed or a stroke, like a hemorrhage or an infarct. Um, and also any uremia. Would like to rule out other metabolic and electrolyte causes as well. And since the patient has been in the ICU, I would like to think of ICU delirium as well.
No, low GCS continue to be E1, V1, M1, E1, VT, M1.
Even
Throughout the
even
course, it is not now.
okay. Okay, this has been post cardiac arrest, so it could be an hypoxic injury to the brain.
Yes. Okay. So in this patient, you should always consider hypoxic brain damage. Okay.
Yes.
Okay. How will you approach to diagnose those things?
So this patient, first we have hypoxic injury to the brain must be the last. We have to rule out other causes of poor sensorium. Like had mentioned, any infarct or any other electrolyte abnormalities, and also do an MRI to find if there are any changes. Also like to do other tests like EEG.
Hmm. Okay. So you'll consider doing imaging, electrolytes, and EEG. These are the three main tests you'll consider. Okay. I
Okay.
think that's it with the case. So you did very well. Even though you didn't get diagnosis, it's not about getting the diagnosis per se in the exam, especially in the EDIC and IDCCM. It's about the approach. Okay.
Okay.
Just because you didn't get chylothorax or ascites, it
Hmm.
doesn't mean that you'll fail in the exam. It's all about the approach. If you're able to understand how you approach a case, you'll definitely pass. You don't have to worry about it. Okay.
Okay.
Sanjana, you've done
Yes,
very
sir.
well.
Uh,
But I would like to, because we told it's a cardiac, there are a lot of things I didn't
hmm.
discuss also. I
Hmm.
just like to touch upon it.
Yes,
Okay.
sir.
What are the complications of ACS?
Cardiogenic shock, arrhythmias, papillary muscle rupture, ventricular septal rupture.
Yes. Okay.
Mm.
In the exam, no, within 7 days after ACS, any complication comes, always try to attribute it to ACS rather than something new. I don't
Okay,
think
sir.
you'll get a case of sepsis or pneumonia, especially
Mm.
in the context of cardiac. Okay.
Yes,
Generally,
sir.
try to think it as a cardiac cause unless something different scenario is there.
Yes, sir.
As antiplatelet therapy, as you currently told, is ticagrelor we are using at this point of
Yeah.
time. But evidence says that post PCA, prasugrel might be better.
Okay.
Okay. And you told heparin and clexane.
Yes, sir.
Generally, it is not used. Only if it's a high risk of thrombosis, they're
Mm.
suspecting high burden, clot burden is there. Then they use heparin or clexane, even tirofiban also used in that context. Okay.
Okay, sir.
Okay. So the other words they you ask is rescue PCI. What is rescue PCI?
So it is done if the thrombolysis has failed, or if the patient does not have any resolution of the symptoms post thrombolysis.
Okay. Any scoring systems you are aware of? It might be part of MCQs, but just I'm asking you. So
Uh,
stratification of ACS scoring, myocardial infarction.
yes, sir. So type 1 MI will be because of
No, I'm not asking classification of MI.
okay.
Stratification,
Mm,
prognosticating.
no,
Okay.
sir.
Just remember, you don't have to by heart this. Just
Hmm.
remember that there's something as grace risk score and
Grace.
a higher Timmy score.
Yes,
Okay.
sir.
Timmy flow and Timmy score are different.
Hmm.
Okay. What about bleeding? Any scoring system to stratify bleeding?
Yeah, the Crusade scoring system is used. This
Yes.
to
Okay.
check the risk of
Basically, just
bleeding
a part of
post.
MCQ they might ask. Okay.
Yes, sir.
Okay. Modified ECGs. In what cases modified ECGs are done?
In cases of posterior wall MI,
Okay. Which leads you'll have?
V7, V8, and V9, and at the back.
Well, okay. Then any other modified?
Mm.
V3R or V4R, right ventricular MI.
Okay.
Okay. How fast you should do an ECG in case of ACS?
Within 10 minutes.
Okay. I think other nothing I didn't touch upon is especially if you don't have PCI, how fast you should do thrombolysis?
Total needle time will be less than 30 minutes.
Okay. When you can refer to a PCI center? Within how much duration?
Within 90 minutes, sir.
I think within 2 hours, I guess.
Okay.
Okay. I think definition of ST elevation, it can be asked as an MCQ as well as that. This thing you can read it. I will not going to touch it.
Yes.
And you are aware of Garbosa criteria?
Yes, sir.
Can you tell me what exactly is it?
So Barbosa criteria is used. It is like if there is a new onset left bundle branch block. So we use this Barbosa criteria to check if it is an acute MI. So here there should be ST elevation in the
No,
concordant
wait. I'll just
leads.
clarify you, Sanjana.
Yes, yes, sir.
It is used in case of patient is pre-existing LBBB.
Okay.
Okay, now go ahead.
Okay. Yeah. So here we have to look at ST elevation more than 1 millimeters in at least two concordant segments,
Hmm.
or an ST depression of more than 1 millimeter in V1, V2, and V3.
Hmm.
And if there is a discordant ST elevation, it should be more than 5 millimeters in the leads.
Okay, that's good. Okay. What are STEMI equivalents?
STEMI equivalents are new onset LBBB, Deventer sign, Wellen sign, and ST elevation in AVR lead,
Yes.
and also posterior wall MI, and uh, T
Good.
wave, hyperacute T waves.
Okay, very good. Now they have come up with a new word for STEMI, yeah, because there are a lot of STEMI equivalents are there which people don't diagnose otherwise if it is not a STEMI. So to avoid using the terminology, now they are using a new word known as occlusion myocardial infarction. Okay, it is coming up.
Okay.
It might come in further textbooks and articles and all. You'll see more of it. Occlusion myocardial infarction. Okay.
Yes, sir.
What are STEMI mimickers you are aware of?
Yes, sir. So STEMI mimics include left bundle branch block, any coronary vasospasm like angina, then it could be any pericarditis, or other causes including elevation like SAH, any paced ventricular paced rhythm, left ventricular hypertrophy, and left ventricular aneurysm.
Yes. You should remember hyperkalemia, you should remember aneurysm, you should remember Brugada, pericarditis. These are most commonly you see that having a STEMI mimicus.
Yes,
These
sir.
are conditions which looks like STEMI, but they are not STEMI. Okay.
Mm.
Okay. So QA sometimes they might ask in MCQ, you can read about it. That's it. Okay. How did you think you performed, Sanjana?
I don't know, average.
No, you did very well actually. I told you, no. In the
Uh,
exams, it's not about getting the accurate diagnosis. It's all about the approach. Okay.
okay,
Hypothermia and this chylothorax or chylosocieties have come in the exams, especially
okay.
EDIC exam they have come. I'm
Mm.
not sure about the ID system will be more straightforward. They might give an ACS scenario. They might give us like MR, mitral regurgitation is given. No? They might give a scenario like that. Or sometimes they might give a ECG which is normal, accelerated idioventricular rhythm. They might ask what is it exactly. How will you approach if
Mm.
the patient have accelerated idioventricular rhythm? Or they
Okay.
might give a complication of cardiac tamponade. So these are the scenarios generally you see in the exam.
Yes, sir.
Okay. Uh, does anybody have any other questions? Any feedback anybody want to give? Shravani, anything you want to say?
No, sir.
Okay. Thank you. If you have any questions, any queries, you can send me personally a message. Okay, I'll answer it. Thank you everyone for attending.
Thank you so much, sir.
Thank you, sir.